patient-centered approaches. Thank you again for being here. It's my honor to kick off the evening by introducing our first session, Understanding and Diagnosing MASLD and MASH, What PCPs Need to Know, moderated by Dr. Rick Ward and featuring Dr. Mazen Noureddin. Enjoy this very special event, and over to you, Rick.
Hey, thanks very much, Michael. And just want to echo the words that you've said about how exciting this meeting is and how important time it is in the field of knowledge. As a primary care physician practicing in Calgary, we see patients with fatty liver every day, and exciting that we're now looking at ways of approaching these, understanding the comorbid conditions. So great to be here. I want to remind what Michael said, that please, this is meant to be interactive, so throw your questions in the chat. Without further ado, though, I want to call on Dr. Noureddin to really kick us off with some level setting about understanding and diagnosing MASLD and MASH, what the primary care physician needs to know. I believe just off a plane and back home. Mazen, take it away.
I'm actually not quite back home. I'm away from home in Ann Arbor, Michigan, in the snow coming from Texas, where it was much better. But anyways, glad to be here. Michael, for a second, I thought that I need to speak French with subtitles in English, so I had a heart attack, but then I read it correctly, and it looks like I have to do it in English, luckily. So let me tell you about the diagnosis of MASLD and MASH and what primary care needs to know. And as Dr. Ward mentioned, this is a very common and prevalent phenomena, especially in those with type 2 diabetes. This is a study from Zubair Younasi showing you the prevalence of fatty liver, and I'll get to the definition in a second. What we call it now MASLD is 51% in the diabetics. So each in two patients, if you have two diabetic patients, one of them, they have MASLD. And unfortunately, the prevalence of advanced fibrosis, which we define as F3 or F4, is 17% of this population. I tell my fellows, this is the elephant in the room, type 2 diabetes. So you really have to pay attention to this population. And guess what? The prevalence of this condition, MASLD or type 2 diabetes or insulin resistant, is not changing around the world. If anything, it's increasing, unfortunately. So it's a pandemic, epidemic, whatever you want to call it. And it's our duty now to pay attention to these patients that I see in my hospital, sometimes really late, needing liver transplantation. I just came off transplant service, and unfortunately, many decompensated MASH cirrhotics that they come to us too late sometimes, and there's nothing to be done for them other than liver transplant. And as you know, some don't make it. So I showed you the prevalence of type 2 diabetes is a little bit less in the general population, but it's not that rare. It's actually 30% in the general population. And Zubair has shown over the years, Dr. Younasi, that we started with him in the 23, 25, and it's all the way up in 31%. In other parts of the world, such as the Hispanic population, Latin America, it's 4%. In other parts of the world, it's really also highly prevalent. So this is not a trivial problem. This is what I see in my clinic all day, and it's overflowing clinics. And we want to know which patients we need to target and which patients we want to pay attention, and who needs a hepatologist versus a primary care physician. Other data showing that this is like the colors breakdown is showing you the fibrosis stages, and on the top you see the F4 cirrhotic patients in purple, and the blue F3, green F2, and then F1 and F0. And what it shows you in this very well-known paper, a prediction model between 2015 and 2030, where the prevalence or this disease projected the NASH to increase by 63% in the population. No bueno. This is not good news in general. Those are data that came from us as well as Younasi's group. And what I show you here in the left, and this is a really success story that success and an alarming story at the same time. And I really like these kind of studies. On the left, you see the leading cause of liver transplantation over time. And what you see here in red, pay attention to this red line. What is that? Look at it. It's decreasing over time. And what was the curve point? It's 2013. And what is that? It's hepatitis C, actually. In 2013, when we developed the direct antiviral therapy, and guess what? Hepatitis C is not leading cause of liver transplantation anymore. It's actually one of the very few curable liver disease nowadays, and we don't see them in our clinic. What a success here. What I'm showing you, on the other hand, on the same graph in purple and in green, purple is alcohol, green is MASLD or MASH as leading cause of liver transplantation. In a paper that we published, here cited below, we showed that MASH is the leading cause of liver transplantation in women. So both these pandemics or epidemics are quite alarming. On the right, you see the leading cause of liver transplant from HCC. So etiologies can cause cirrhosis and eventually can lead to liver transplant. So alcohol leads to cirrhosis, then you develop HCC. Same thing for MASLD and MASH. Same thing for hepatitis C. And what you see here, exponential increase of MASH as cause of liver transplant for HCC in our patients. Also very alarming data. For those that they don't know, that in the last year or so, we have changed the nomenclature. So MASLD used to be called NAFLD, but what we figured that fatty liver can happen from multiple causes. And there were a couple of issues with fatty liver, or the term fatty liver. Patients really did not like that term, fatty, stigmatizing. Sometimes we use also to say like the non-alcoholic, and you tell them you have non-alcoholic fatty liver disease. And what would the patient take home with him is these two words, non-alcoholic fatty. And sometimes they go to their neighbors and say, I have non-alcoholic fatty liver disease. And whenever people hear liver disease, they forget about the non and they think the patient is alcoholic. They start stigmatizing the word fatty. Those patients are usually overweight and have metabolic syndrome. So there was a call for changing this nomenclature, went through a lot of debates around the world, and we ended up with this algorithm. So what's this algorithm showing you? On the top, you have steatotic liver disease, which is very much steatosis or fat in the liver. And on the left, you see what used to be NAFLD, it's MASLD now, metabolic dysfunction associated steatotic liver disease, or we call it MASLD. And the advanced form, it's called MASH. And on the right, you see alcohol-related liver disease, which is a cause of liver transplant, one of the causes of liver transplant. And in the middle, this area in between, that patients drink more than the allowed for MASLD, yet they're not that as heavy drinker, but still they have a significant amount. And on the right, you see like steatosis and the setting of other problems. So no more NAFLD, it's MASLD, NASH is MASH. And part of also what the good diagnosis, it put the disease in context. This is a disease that a lot of people think it should be part of the metabolic syndrome. And the nomenclature and the guidelines call for the diagnosis of metabolic features. And at least you need one of those as listed here on the left. And we can send you the slide or take a picture rather than me going through them, but primary cares are well aware of those, maybe better than the hepatologists, and now we're paying more and more attention. And why so? This is actually a multisystemic disease. If you have a MASLD patient, I bet you if you look for something else in metabolic syndrome, you will see it. Either increase in adipose tissue, increase in body weight, eventually they get kidney problems, they have some cardiac features, including atherosclerosis, HFpEF. So you see these cousins, if I want to call them, actually associating with each other, and the burning pathophysiology is insulin resistant, then a cascade of inflammation, and in the liver, you eventually can get a downstream activation of stellate cells and fibrosis. So it's a multisystemic disease that luckily the hepatologists now are looking at the entire picture, but of course, with the help of you guys looking at the cardiac, obesity, as well as kidneys, but still the liver is a challenging one, especially when you get to advanced fibrosis. So let's establish the MASLD rules, I guess. Know like who we need to pay attention to and who we do not need to pay attention to. So the MASLD is the big umbrella. And if you lift, and I leave some of the old terminology here, if you lift the D on the left here, you see the MASLD, which is very much just steatosis on the liver. And this is the majority of patients, luckily. So the reason why I say luckily, most of the time, nothing happened to these patients. However, about 20% progress. And what I tell my patients, this is when you get gas on fire, the inflammation and the cell ballooning and the injury. And why so? Because those also additional 20% of them, they get to fibrosis stages and eventually cirrhosis. And you see here two big boxes that this is what you guys need to pay attention. Not necessarily with biopsy, but you need to focus on those that they have stage 2 fibrosis and higher, because I'll show you in the next slide. And the cirrhosis, it's too late. Why so? If you see here the stages of fibrosis, I put boxes here on once you hit the F2, F3, and F4, when things get really bad, you have increase of all causes of mortality and liver-related mortality. And this is why you saw that box, us focusing now on clinical trials and therapeutics in MASH and F2 and higher. So we break the MASH2 and F3 in one pocket and the cirrhotics in another pocket. We also call this, if you just hear the term MASH F2 and F3, MASH with significant advanced fibrosis, or at risk MASH, at risk of having all the bad stuff. So that's why American Gastroenterology Association, European Association for the Study of Liver Disease, American Association for the Study of Liver Disease, American Association of Clinical Endocrinology, you name it. Now they're calling for this. And this is when we really, guys, can change lives and help us. Now it's mandated to screen for MASLD. And the guidelines, the Endo and GI and Liver Society say if you have type 2 diabetes or 2 metabolic risk factors, of course, elevated liver enzymes, you need to do a test called FIB4. And FIB4, I will tell you about it in the next slide or so, but it's like it's sitting in front of you in the chart, which is HAST platelet and platelet count. You go Google it, or if you have Epic, Epic will spit it out for you, and it gives you numbers. Less than 1.3, this patient is to you. You manage it better than hepatologist. More than 1.3, and remember that number, more than 1.3, this is when patient need a second test, which is transient elastography. There are multiple machines out there, FibroScan, hepatoscope, you name it. And what you see here, numbers. If it's less than 8, also the patients go back to you. But between 8 and 12, this is when you need additional confirmation. More than 12, when things are really serious and we need to explore these patients. This is the ASLD guidelines, same thing. But also in addition to the VCTE or transient elastography, there's additional test in the FibroScan and in the guidelines, which is called ELF, which is a blood-based test. So you can send that test if you don't have access to transient elastographies. This is, again, the ACE guidelines, same story, and all speaking the same language. This is the FIB4 that I showed you about, and I talked about HAST, platelet, and ALT, less than 1.3, low probability of advanced fibrosis. More than 1.3, you have 2 zones, indeterminate, and then more than 2.67, this is when you really need to pay attention. I belong to a network of PCPs, and that's what they do. Once it's more than 1.3, we send it in the network with transient elastography, and they see me if the transient elastography more than 8. And this is what I'm talking about here, 8 to 12. they come to me, I likely do additional tests, and more than 12, this is what the patient you really need to pay attention to. So I just wanted to let you know that those are the fibrosis tests. FIB4, we talked about ELF, VCT, and MRE, and there are additional tests. I'm not going to get deeper to them, but let me talk to you about the transient elastography. This is a machine that looks like this, has two things, one or two output numbers. You see it here on the screen is not that clear. One is blue, one is orange, and the blue one shows you the amount of the steatosis, and the orange one shows you the amount of fibrosis or stiffness. And again, that orange number, I tell my patients, if it's more than 8, we need to talk. You're staying in my clinic. If it's more than 10, and those are some of the numbers, this is the numbers of steatosis, 274, 290, 302. I focus a little bit less on the steatosis, but 8, we need to talk. 10 is getting serious, which is likely F3, and 14 when we start talking about cirrhosis number. ELF, I told you about it. If you don't have access for transient elastography, more than, I say, 9 is like concerning, 9.8 really concerning, which is advanced fibrosis. And more when you get to 11-ish, this is actually patients that might decompensate. So again, you start with FIB4, and then more than 1.3, you pick either transient elastography or ELF. So those are some advanced steps. I'm not going to go deep into them, but there are tests such as MR fat fraction. And here I show you, if you have doubt, there's MR elastography, not available everywhere, but it's a more accurate test than the transient elastography that you can see me do it in clinic. But the bottom line, why I show you those, that you actually really can avoid liver biopsy in these patients. Those are the ASLD guidelines. And on the left, it shows you the FIB4 more than 2.6, 2.67 correlated with the stage 3 fibrosis. ELF more than 9.8 correlates with that. VCTE more than 12, and this is the MRE number. On the right, I show you the rule-in numbers for cirrhosis. So FIB4 more than 3.48 is likely cirrhosis. ELF more than 11.3, and the transient elastography more than 20 is very, very concerning for cirrhosis. And MRE more than 5 is also very concerning for cirrhosis. There are some additional new blood tests. Why I'm throwing all those on you? Because we started FIB4, and people say, well, I don't have an access for transient elastography. I just have access, and I don't have access for ELF. This is an example of a test called MASLD test, which is actually now commercially available in the US, and it shows you those with NASH and F2 and higher. There's another test that is not commercially available. It's called NIS2. Again, I showed you that MASLD by OWL is commercially available if you don't have access to the ELF. Now I'm finishing up here, like some data that we put recently. If you heard of resmetirom, as the first FDA drug approved, and here we put a expert consensus on how to start treatment on these patients and how to monitor them. So I think this is the gist of it, and we simplified it here. If you get a MASLD patient, you rule out other causes, and then you assess fibrosis. And here the green and orange needs to be treated. And if you see 10 to 15 on transient elastography, we want it to be specific, and then 15 to 20. So it's between 10 and 20. The reason why this is orange, because you can start hitting cirrhosis here. And what we say, pay attention to not include cirrhotic here. And you can do that by making sure the platelet is more than 140 and there's no evidence of portal hypertension on the slide. You can use also MRE or ELF score. VCTE here on the red, more than 20, you don't want to treat the patients because he's cirrhotic, because it's not approved yet for cirrhotic, or MRE more than 5, or ELF more than 11.3. So you can use any of those. Most people use transient elastography and liver enzymes to start and monitor. And how does that look like? In our consensus paper, I showed you how to start. In 3 months, we repeat liver enzymes. We don't act on it. In 6 months, we do liver enzymes or one of PDFF or transient elastography. And we don't act on it until month 12, because the resmetirom trial was done for over 12 months. And here we look for changes in ALT by 17 units, or VCTE by 30%, or PDFF by 30%. Again, let me walk you through it. You start resmetirom, as I showed you from this previous slides, and we're happy to share the slides. And then 3 months, you repeat liver enzymes, 6 months liver enzymes, and let's say transient elastography. And you don't make a decision until 1 year when you want to see liver enzymes dropping by 20% and the stiffness dropping by 25 to 30%. And this is when we decide to continue or maybe stop. So in conclusion, ladies and gentlemen, MASLD is epidemic. We changed the name. You really need to screen the high-risk population, especially the diabetic with FIB4. There are multiple biomarkers, but the most relevant to you is ELF and transient elastography. And I showed you another one such as MASIF and others. If you do combination of tests, it's always helpful. I always use either ELF and transient elastography or transient elastography and MRE. It will narrow down I will show you how we monitor the new therapies on it. And with that, I'll stop here and pass the baton, I guess.
Yeah, thanks, Mazen. And that's a very apocalyptic presentation in many ways, just seeing the tsunami that is coming down the road. We've got a question from Margot, who asks about what's the role of MRI in assessing fibrosis?
Yeah, so it's not a first line, definitely. You can get away with ELF and transient elastography. There are these data, especially in overweight patients. Transient elastography is 14 and 15 and 16. Some people, it's sensitive for cirrhosis, but it's not specific. So when I get 15, 16, I see a lot of gastroenterologists trying to scare the patient and say you have cirrhosis. Not the case. And this is when sometimes I want to avoid biopsy, I get this MR elastography, which is the only one that assesses fibrosis. You really don't need it because it's not available everywhere. However, it is very helpful. If you don't have it, you can add another test to that transient elastography, such as FIB4 and ELF.
Right. So, Dr. Pak Arash asks, what are the limitations of FIB4 as part of your
Thank you, Arash.
investigative algorithm?
Thank you, Arash. And this is very important for the primary care physicians. So it does have limitations. So age more than 65, we don't use the 1.3, we use the cutoff of 2 because age is moving, so the score moves up. Also, there are some limitation in type 2 diabetics. It's not super perfect and in age less than 35. And you might be saying, is like, why use it then? Like, why you're throwing a test on us if I'm gonna miss? Well, first of all, we were not doing anything before. So we really want people to screen. 2, it's cheap and sitting in front of you. And 3, you actually can repeat it over time. And with the repetition, we're not gonna miss. So in 6 months, if you repeat it, or a year, you can repeat it once a year, it will capture this slack and make you more confident in what you have.
Question that I have, you've made a really compelling argument that we must be looking at all of our type 2 diabetics for fatty liver disease, MASLD. Who are the other patients that primary care should be focusing on for screening?
Yeah, I mean, a patient with, for instance, 2 other metabolic features other than type 2 diabetes, so overweight, hypertension with the waist circumflex, dyslipidemia and hypertension, they still can have F3 and F4. So it's per guidance, prediabetes, diabetes, or 2 metabolic risk features or elevated liver enzymes.
And what's the follow-up period? Assuming that you have somebody that has a low FIB4 rating, how frequently should these patients be followed up, and how should they be followed up?
Yeah, I mean, the guidance says every 2 to 3 years. I think that would change. I'm a little bit on more the cautious side, and it's not costly to have ALT, AST, and platelet and age. I mean, the age is always there once a year. So I say if you have systems like Epic or other EMR that can pop out that FIB4 formula, and there are many of them, do it at least once a year.
Great. A common scenario in primary care, at least in my world, is you're doing an ultrasound for belly pain or some other investigation that makes comment of fatty liver noted on imaging. You do liver function tests and they're unremarkable. What's the next step?
I will do the FIB-4. The reason why is, or if you have even better, if you have access to transient do it. Be my guest. I probably wouldn't, as a if it's my family member, I would do the transient. But the FIB-4 also, even the numbers are normal. Sometimes you have normal liver enzymes despite having fibrosis. So the AST-ALT ratio, even if they're normal, the flip in the lower platelet and all that should alert you enough. But to me, if it's like you're my cousin and you have that, I'm like, hey, Rick, just get your transient or get an ELF.
Right, jump right to that. And I guess the other filter that you're going to look at this is the rest of the metabolic profile. You're not just going to look at the imaging. You're going to look at as you again made the great case, if this patient has metabolic syndrome, then you're going to go right to an investigation that's going to give you the money.
And also, like, there's elephant in the room, alcohol. You wanted to talk to them about their alcohol intake and all these things.
Yeah, good point. So again, what advice do you give then for your patients with early stage fatty liver and alcohol? Is it 0-0 or is there an accessible threshold?
Yeah, I was having actually a debate among our my hepatology colleagues, and there are data to support you should not give any alcohol. There are data showing that zero alcohol is the safe amount, and more than that is not a safe amount. I personally say if you want to have a drink here and there, be my guest. If you have fatty liver from non-alcohol for Christmas or something or New Year, but in general, like we limit it. If you get to F3, F4 for sure, that's like you gotta stop.
Yeah. Good. Listen, we've got a couple of questions before we let you off the hook. Shannon Bowman says, I see celiac disease as a risk factor with adherence to a strict gluten-free diet. Does this change the risk back to an individual without celiac, or are there other aspects?
We don't have data on the gluten-free diet changing the natural history of MASLD.
Great. So stay tuned for more information on that. And again, Robert Gish makes the point, and I think it's just a point, that liver enzymes versus liver function, and maybe our nomenclature isn't perfect in that, so we'll take that as a point. Bruce Denning, in addition to these metabolic risk factors in assessing for possible liver disease, PCPs also need to be aware of comorbidities that can be indicative of liver disease. If they have any of these, the PCP may want to further triage the patient. Any comments on that quickly,
Need to be aware of comorbid that can begin of liver disease. I mean, of course, it's like thank you, Bruce. Great question. The comorbidities, you need to look at it carefully. The other factors and ruling out viral hepatitis and all these things. Very important point.
Good. I'm going to finish this off with a couple of questions. Jerome says, how reliable is FIB-4 to follow up and assess progress after lifestyle? So you make the diagnosis of early fatty liver disease, you encourage lifestyle intervention. Would an improvement in FIB-4 be, would that reflect improvement in the condition through lifestyle?
That's a great question. Let's say a patient that has a FIB-4 less than 1.3 and he stayed with the primary care. It's usually following in the normal zone. So I will look at liver enzymes. I will look at the steatosis and ultrasound is improving. If it's more than 1.3, it's probably meaningful. There are some data on that. But at that point, if he has fibrosis or a disease, we usually monitor with more advanced tools.
Good. Listen, I'm going to finish this off, or finish this section off with the question around Aresh Pak. At what stage of fibrosis do you feel comfortable primary care doctors can manage MASH? So when should we put in that referral for a patient to see hepatology?
So what we're telling people, if it's the FIB-4 is more than 1.3 and the transient elastography more than 8 or alpha is elevated, that's when it's belonged to the hepatologist. Now, if you do not have access to these two, I showed you other tests. If you still don't have access to those two, send the FIB-4 more than 1.3 and we'll take care for it for now until people get more comfortable with it.
Good stuff. And from the numbers that you've given us at the beginning of your presentation, clear that there's going to be enough work for primary care on those patients with early stage disease.
We just don't want to miss
Thanks.
the cirrhosis for sure.
Exactly. Yeah. Mazen, thanks very much for being the lead off hitter, and enjoy the Michigan snow for your time there.
Pleasure.